there's one outlier to this that I'm really curious about, because this is I think a trial, NSABP B41, Hope, where they did get all the therapy up front, did have a small PCR benefit, and in fact, I believe the data as reported at ASCO actually had a disease-free survival benefit, did it not, to the addition of Lapatinib?
No, there's one study, interestingly, in the neoadjuvant setting that suggested some DFS benefit in the ER-positive subset, and that's actually the German trial that suggested that potentially
Quinto,
that suggested that potentially continuing Lapatinib with hormone therapy, because we start the hormone therapy after surgery and radiation, might have some advantage, which is kind of intriguing given the data that I know we'll talk about with neratinib, another oral tyrosine kinase inhibitor, because I think there may be something there. But otherwise there wasn't. And B41, it's an interesting question because we also have the Lapatinib data from the CLGB trial that Lisa Carey published quite recently. And that one is mainly, I think has really helped a lot in terms of biomarker data, but in terms of the addition of Lapatinib, very hard to interpret any information. In that one also the anthracycline was given after, but I think, we don't know, and I think there's a lot of issues there in terms of how people tolerate neoadjuvant therapy, how much they get, the ER positive versus negative differential, et cetera.
So just before we move on to TDM1 in the neoadjuvant setting, I just want to kind of ask everybody, so you think, at least in the adjuvant, neoadjuvant setting, I think probably Lapatinib does not have a future or has a future? I'll start with Ahmad. Think Lapatinib is done?
I think it will be difficult after following the result of the ALTO trial, let's say, to support Lapatinib in the neoadjuvant setting. But for the other drugs, surely for pertuzumab and for neratinib, we should wait a little bit more data to come.
Gotcha. Hope?
I agree. I think that there is likely an ongoing benefit of Lapatinib, at least until neratinib is approved, for patients who have resistant disease. And I've certainly added it in people with early relapses on a trastuzumab-pertuzumab combination.
Michael?
Before giving a yes or no answer, which might be the simplest way to do, let me just recall what Hope was mentioning to the Quinto study. Since I'm the PI of the Quinto study, the Quinto study is actually a negative study because...
Could you explain, though, for the audience what the Quinto study was, just in case people don't know?
Yeah. So the neoadjuvant portion of the Quinto study was the comparison of Lapatinib with trastuzumab and with the double combination. Now, the problem of Quinto is giving us a very nice hypothesis for the future, and I'm going to end up with the story of neratinib. Because in the Quinto, actually, we gave 6 months of neoadjuvant therapy, and in those 6 months of neoadjuvant, or after 6 months of neoadjuvant therapy, the Lapatinib component, or the Lapatinib arm, was inferior, number one. Number two, all patients received 12 months standard therapy with trastuzumab after surgery. So actually, the patients in the Lapatinib arm ended with 18 months of treatment with a sequence of a tyrosine kinase inhibitor and trastuzumab, and those other patients in the standard arm had 18 months or 1.5 years of trastuzumab. Now we know that trastuzumab 2 years is not better than 1 year, and that was exactly the same result in our study. But interestingly, the hormone receptor positive patients had a survival benefit from the receptor tyrosine kinase inhibitor portion and trastuzumab. So I was then looking to the literature, and I ended up with Extenet trial, in which we see exactly the same effect. So I think Lapatinib was used in the wrong way when we designed the trials, and probably we should learn from the neratinib trial, which I think we are going to focus in a moment.
We'll talk about it in a few minutes, yeah.
Okay, so my answer is Lapatinib at the moment in the adjuvant and neoadjuvant setting is a no, because we are not using it. We have better options.
Right.
And how to use an extension of anti-HER2 therapy is the story with neratinib.